Good morning, everyone. My name is Dr. Melanie Gomes. I'm a senior resident in the Department of Orthopedics at Sri Lakshmi Narayan Institute of Medical Sciences, Puducherry. Today, we'll be talking about osteoporosis and recent advancement in the management of osteoporotic fractures. First, coming to what is osteoporosis? Osteoporosis is an acquired condition characterized by reduced bone mass, leading to bone fragility and susceptibility to fractures. WHO, that's the World Health Organization, defines it as bone density as measured by DEXA, that is more than 2.5 standard deviations below the mean bone density of a healthy young adult. That is the T-score. Bones are composed of a unique type of mineralized connective tissue that undergoes mineralization with a distinct admixture of basically two components. One is the organic matrix, which accounts for 35%, and the inorganic elements, which account for 65%. The organic matrix is basically the calcium hydroxyapatite, and the inorganic elements are the cells of the bone and the proteinaceous osteoid. Of the cells of the bone, we have bone-forming cells, which are the osteoblasts and osteocytes, and the bone-digesting cells, which are the osteoclast precursor cells and mature functional osteoclasts. Bone is subject to constant breakdown and renewal, and bone is subject to constant breakdown and renewal, a process referred to as remodeling. Osteoblast and osteoclast activity is highly regulated and is tightly integrated by local crosstalk between these two cells and circulating factors that impact the activity, such as vitamin D and parathyroid hormone. As you can see here, the osteoblasts contain the rank ligand and the osteoclast precursor, the rank ligand receptor. The interaction between these two results in the differentiation of osteoclast precursor cells into the mature osteoclasts. However, in presence of osteoprotogerin, which blocks the rank ligand interaction, this prevents the differentiation of osteoclast precursor cells into the mature osteoclasts. Coming to the pathogenesis. Osteoporosis occurs when the dynamic balance between bone formation by osteoblasts and bone resorption by osteoclasts tilts in the favor of resorption. And there are several factors which may tip the scales. One is the genetic factor. Now there's nutrition and physical activity. Now, in case of aging, there is decreased replicative activity of the osteoprogenitor cells. There's decreased synthetic activity of osteoblasts, decreased biologic activity of matrix-bound growth factors, and reduced physical activity, all resulting in osteoporosis. In menopause, there's usually a decreased serum estrogen, increased interleukin-1, 6, and tumor necrosis factor levels, increased expression of the rank and rank L, and increased osteoclast activity, all again resulting in osteoporosis. Now coming to the types of osteoporosis. Broadly, there are two. One is your diffuse osteoporosis of a limb and the generalized osteoporosis. The generalized osteoporosis is further classified as primary and secondary. And the primary further classified as type 1, which is your postmenopausal, and type 2, which is senile. Now, what is the difference between the type 1 postmenopausal and type 2 senile? Type 1 is more commonly seen in females between 50 to 70 years of age, affecting mainly the trabecular bone. The common fractures are the vertebral and distal radius fractures. This is the cause for postmenopausal osteoporosis is usually an increased osteoclastic activity seen after menopause in females. Type 2, which is the senile osteoporosis, is seen in both sexes after 75 years of age. This affects the trabecular and cortical bone. Here, commonly, we see the vertebral and the hip fractures. The cause for type 2 osteoporosis is basically a reduction on osteoblastic activity with age. Coming to secondary osteoporosis. This can occur in endocrine disorders like hypoparathyroidism, hyperthyroidism, hypogonadism, pituitary tumors, diabetes, mellitus type 1, Addison's disease, neoplasia, multiple myeloma, then gastrointestinal disorders like malnutrition, malabsorption, hepatic insufficiency, vitamin C and D deficiencies. Certain drugs can also result in osteoporosis, like anticoagulants, chemotherapy drugs, corticosteroids, anticonvulsants, and even alcohol. And miscellaneous other causes like osteogenesis imperfecta, immobilization, and pulmonary disease. Coming to the clinical features. Commonly, what we see is pain. They may have lumbar backache, which radiates around the trunk or to the lower limbs, which are aggravated by movements. Usually, it's an acute, sudden onset of pain with localized tenderness in the chest or back. An acute sudden onset of pain with localized tenderness in the chest or back is more suggestive of a pathological fracture of the rib or the vertebral body. Loss of height with the appearance of the thoracic kyphosis, also called Dowager's hump, and approximation of the rib cage to the iliac crest can be seen. Another symptom is early satiety due to abdominal compression resulting from the loss of height of vertebral column. Shortness of breath may also be seen. This is due to the increasing kyphosis in the dorsal region. A number of fractures are specifically associated with osteoporosis. These are vertebral body fractures, fracture neck of femur, COLLES fracture, supracondylar fracture of femur, the distal tibial metaphysis, fracture neck of radius, and subcapital fracture of the humerus. In case of vertebral body fractures, patient may not even recall a traumatic incident. When it comes to vertebral body fractures, initial change may just be intrusion of the vertebral disc into the bone, leading to a biconcave vertebra, then followed by progressive loss of height. Osteoporotic fractures may cause very minimal pain or very severe with a band-like dermatomal involvement. Most commonly affected vertebrae is the lower thoracic and the upper lumbar, primarily T12. Coming to the diagnosis of osteoporosis. Investigation of osteoporosis directed towards exclusion of underlying abnormalities which account for the osteoporosis. First, plain radiographs, they cannot reliably detect until 30 to 40% of the bone mass has already disappeared. One thing that can, serum levels of calcium, phosphorus, and alkaline phosphatase can be done. However, they're notoriously insensitive. Measurement of bone metabolism in vivo by bone markers can be done. Where here, fasting urine, we can check for the calcium, creatinine, hydroxyproline, creatinine, 24, and pyridinolines, creatinine. However, the current gold standard for measurement of bone mass and for diagnosis of osteoporosis is DEXA, which is dual energy X-ray absorptiometry and quantitative computed tomography. This, as you can see, there's a reduction, osteoporotic fracture of the L4, where there's a loss in height of the vertebrae. Another thing to grade osteoporosis is something called the Sings index. Here we take the trabeculae seen in the proximal femur, the appearance or lack of, to grade it. We have the primary compressive, the primary tensile, the secondary tensile, the secondary compressive, and the trochanteric. When all can be seen, this is grade 6, which is normal. In grade 5, the trochanteric disappear and the secondary compressive trabeculae, the number is seen to be reduced. In grade 4, the secondary compressive have completely disappeared and the secondary tensile are seen to be reducing. In grade 3, the secondary tensile have completely disappeared and only the primary tensile and primary compressive are still visible. In grade 2, the primary tensile have completely disappeared. Only the primary compressive trabeculae lines are still seen, and in grade 1, even the primary compressive tensile tends to decrease. Coming to the management of osteoporosis, we have the medical and the non-medical methods. Medical methods with the help of vitamin D and calcium supplementation, bisphosphonates, teriparatide, calcitonin, raloxifene, denosumab, strontium ranelate, and novel therapies like cathepsin K inhibitors and anti-sclerostin antibodies. Non-medical would include physical therapy, the use of arthrosis, and minimal invasive spine procedures, fracture fixation. Coming to the medical management, one is the elemental calcium requirement in patients with osteoporosis is 1,200 to 1,500 milligrams per day. And the source of calcium is your dairy products. The vitamin D requirement is around 400 to 800 international units per day. Good sources of vitamin D are fish, fish liver oils, and in fortified foods. Supplementation for secondary fracture prevention is usually ineffective, but it can be beneficial in high-risk settings. Next thing is bisphosphonates. Bisphosphonates are synthetic analogs of the naturally occurring compound pyrophosphate. Its mode of action is that it binds strongly to the hydroxyapatite present in the bone, thus inhibiting bone resorption by inactivating osteoclasts. Now, bisphosphonates can come as oral bisphosphonates or parenteral bisphosphonates. The oral bisphosphonates are like alendronate and risdipronate, a dosage of which is usually 5 or 10 mg of daily dose. Its adverse effects are like gastrointestinal complications such as gastritis, esophagitis, abdominal pain, nausea, vomiting, diarrhea, and constipation. This is the reason once the patient is given oral bisphosphonates, we ask them to sit up for at least 30 minutes to avoid such adverse effects. Now, coming to parenteral bisphosphonates, which are usually intravenous, this can be either pamidronate or zolendronate. These are usually given yearly as a yearly dose, 5 mg infusion over a minimum of 15 minutes. Here, the adverse effects, which are commonly seen, are fever and flu-like symptoms. The administration of concurrent acetaminophen, antihistamines, and non-steroidal anti-inflammatory medications help to minimize these transient complications. Now, some rare but important side effects are one with prolonged use of bisphosphonates is osteonecrosis of the jaw and atypical femoral fractures. Contraindications for giving bisphosphonates, those with renal impairment where the creatinine clearance is less than 35 per minute, there's an increased risk of hypocalcemia, low serum calcium, osteomalacia, and patients with esophageal disease. The next option that can be given in osteoporosis is teriparatide. This is a recombinant human 134 parathyroid hormone peptide. The dose is a daily dose of 20 micrograms as a subcutaneous injection. Its mode of action, it increases bone formation. It produces large increases in the bone mineral density, leading to approximately 70% reduction in the incidence of new, moderate, or severe vertebral fractures over 18 months of treatment, together with reduction in non-vertebral fractures. Side effects are usually uncommon, but may include nausea, headache, and dizziness. In addition, transient hypercalcemia and hypercalciuria may also occur. Studies have shown added benefit in combination treatments such as teriparatide plus denosumab, which we will come into, or zoledronate. These are reserved for people with highest fracture risk and very low bone density. Coming to calcitonin, this is usually nasal calcitonin, which is called miacalcin. This is helpful in bony pain secondary to fracture and also works to increase bone mineral density and decrease fracture risk. Analgesia for bone pain is achieved as early as the first to second week of use. The mechanism of activity is not well understood, though endogenous opiate system may play a role in mediating the analgesic effects. It has no protective action in regard to hip fractures. Coming to Raloxifene, this is a selective estrogen receptor modulator where the mode of action is it acts as an anti-resorptive estrogenic effects on the skeleton. Its use has been associated with a significant decrease in the risk of breast cancer. It has been shown to be effective in preventing postmenopausal bone loss and in preventing vertebral fractures. Some adverse effects seen with this are leg edema, cramps, hot flushes, and a 2 to 3-fold increase in the risk of venous thromboembolism. Contraindication with this is patients with the history of venous thromboembolism or previous stroke, as we can see that venous thromboembolism is one of the adverse effects, and also in patients with renal or hepatic impairment. Next is Denosumab. This is a fully humanized antibody to receptor activator of nuclear factor kappa B ligand, that's rank L. It's a newer anti-resorptive agent and administered as a subcutaneous injection once every 6 months. Side effects, though uncommon, may include skin infections, which is predominantly cellulitis. This is thought to be secondary to an immunomodulatory effect of the drug, and also hypocalcemia if the patient is vitamin D deficient or has renal impairment. Coming to strontium ranelate, its mechanism of action is still unknown. It remains a subject of research. There is evidence that it increases bone strength by altering bone material properties. It is usually taken as a single daily oral dose. Administration of strontium ranelate leads to a substantial increase in the bone mineral density. This is due to incorporation of strontium, which has a greater atomic weight than calcium, into the bone. Adverse effects associated with strontium ranelate include increased risk of cardiovascular disorders. The relative risk for myocardial infarction is around 1.6, in addition to the previously known risk of thromboembolism, which also present. Its use now is restricted to the treatment of severe osteoporosis in postmenopausal women with heavy risk of fracture and in men at increased risk of fracture, but with, again, we have to make sure that they do not have any cardiovascular or cerebrovascular disease. Ipraflavone. This is a synthetic derivative of the naturally occurring class of isoflavones. It acts as an inhibitor of bone resorption and an enhancer of bone formation. It's usually given in a dose of 600 mg per day. It prevents increase in serum levels of osteocalcin and alkaline phosphatase activity and urinary excretion of hydroxyproline. These can be ideally used in overreactomized women, those having primary osteoporosis, that is postmenopausal women, Paget's disease or senile, Paget's disease of the bone, and primary hyperparathyroidism. The dose is used in this case is usually 1,200 mg per day. Coming to novel therapies, these are newer therapies that may not be that are still in trial but have just started being used. One is Odanacatib, which is a cathepsin K inhibitor. This is usually given as a once weekly oral treatment. It's in phase 3 clinical trials. The mechanism of action is that it inhibits cathepsin K, a cysteine protease which is expressed in osteoclasts, which degrades type 1 collagen. In postmenopausal women with low bone mineral density, 24 months of treatment with this drug was shown to produce increase in the lumbar spine and total hip mineral density by 5.5% and 3.2% respectively. Later trial outcomes also demonstrated a possible increase in cerebrovascular events, being one of its side effects. Another option is the anti-sclerostin antibodies. This is currently, there are two, which is romosozumab and blosozumab. Sclerostin is an osteocyte-secreted protein which negatively regulates osteoblasts and inhibits bone formation through the LRP5 WNT signaling pathway. Romosozumab is a monoclonal antibody to sclerostin. This is usually administered intravenously to healthy men and postmenopausal women and was shown to increase the bone formation markers along with the dose-related decrease in the bone resorption markers. The other one which is available is a blosozumab, which is a humanized monoclonal antibody targeted against sclerostin. This has demonstrated statistically significant dose-related increase in the spine, femoral neck, and total hip bone mineral density as compared with placebo. Biochemical markers of bone formation were also seen to have increased during treatment with blosozumab, whilst resorption markers decreased. These findings present promise for future use of anti-sclerostin antibodies as anabolic osteoporosis therapy. Coming to non-medical methods of treatment, one is physical therapy. These include balance exercises and strengthening exercises of the bilateral lower extremities and weight-bearing exercises, which in turn can decrease fall risk. Back extensor strengthening exercises, which decreases the thoracic kyphosis and possibly prevents vertebral compression fractures. Aerobics and weight bearing and resistance exercises can increase the bone mineral density in the spine. Walking can result in increased bone mineral density in the hip. Another option is the use of orthoses. One is hip protectors. Orthoses comprised of padding placed in the undergarments worn over the greater trochanter help to absorb the impact on fall. However, poor patient compliance remains the main obstacle to their use. Another thing is posture training support using CASH, which is cruciform anterior spinal hyperextension brace or the Jewett brace. These are usually used in symptomatic vertebral compression fractures to minimize the thoracolumbar flexion. Posture training support may minimize the symptoms accompanying painful vertebral compression fractures. Coming to the management of certain fractures which are commonly seen in osteoporosis. One is the thoracic and lumbar spine fractures. We have to rule out other causes, pathological causes that may have caused these fractures. Vast majority of the cases, these can be treated non-operatively. We need to educate the patient uh, about osteoporosis in this case, as well as further management. We need to treat their pain, and we can give them braces like discussed earlier, like cash or the Jewett brace in case of acute fractures, parenteral calcitonin, and there are options of minimally invasive spine procedures like vertebroplasty or kyphoplasty. In kyphoplasty, once inserting into the vertebral body, the balloon is inflated inside the damaged vertebrae. This helps in increasing the height to normal. Once done, a special material is injected into the fractured vertebrae, and this material hardens and stabilizes the vertebrae. The other option is vertebroplasty, where after inserting a bone biopsy needle into the collapsed vertebrae, we directly inject polymethyl methacrylate, which hardens and providing it stability. Coming to fractures of the hip, these usually include femoral neck fractures, intertrochanteric fractures, or subtrochanteric fractures. Treatment of this is usually prosthetic replacement, which is commonly used in displaced femoral neck fractures. The advantage of prosthetic replacement is immediate mobilization and full weight bearing on the affected limb. It diminishes the need for subsequent operations. For the fixation of a prosthetic device, one, we can use interference or press fit. This obtains stable fixation by the fit of the prosthesis at the time of surgery. Another is the use of cold curing acrylic polymer cement, which allows immediate weight bearing. And the use of porous metals achieves biologic fixation. Initial fixation obtained by press fit, and then fixation is augmented by bone ingrowth into the porous interstices on the prosthesis. This is usually indicated in younger active patients with otherwise healthy bones. Some other options of internal fixation: one, cannulated pins or screws, primarily used for femoral neck fractures in those less than 65 years of age, and usually 3 screws are placed in an inverted V fashion. Another option is the sliding hip nails or screws. This is a single large flanged nail or screw that can slide within a barrel attached to the femur via a plate. This allows for controlled collapse of the femoral neck and intertrochanteric fractures, and allows compression at the fracture site, enhancing stability for fracture healing. Also, it prevents the screw from penetrating out of the femoral head. Intermedullary devices are used primarily, like PFN, are used primarily for intertrochanteric and subtrochanteric fractures. Coming to COLLES fracture, this is the most common fracture of the upper extremity, predominantly seen in females. Here, closed reduction and immobilization in a cast seems to be sufficient. However, open reduction and internal fixation or external fixation device, if Graham's criteria is not satisfied. Complications like mild to moderate residual pain, stiffness of the wrist and fingers, osteoarthritic changes, causalgia, diminished function can be seen in up to 31 patients. Proximal humerus fractures. These are usually seen at the junction of the humeral head and the shaft. They respond well to immobilization for 3 to 4 weeks. If the fracture fragments are displaced over 4 centimeters or angulated more than 45 degrees, more aggressive management may be needed. Internal fixation with pins or screws are more likely to fail due to the poor bone quality. And badly comminuted fractures, a primary hemiarthroplasty can be done, which provides superior functional results as compared to internal fixation. Next, coming to tibial plateau fractures, the primary injury force here is axial loading, frequently combined with angular or rotational forces. It invariably involves the articular surface. The goal here is to restore adequate joint surface and preservation of the complex ligamentous stabilizing structures. Fractures with less than 5 millimeter condylar depression, where less than 10 millimeter central articulation depression occurs, can be managed non-operatively with a cast brace. Fracture healing at the cost of dense intra-articular adhesions and poor knee motion. When there's greater displacement of the fracture, an open reduction and internal joint alignment with rigid internal fixation of the bone needs to be done. When the articular surface is elevated during the process of reconstructing the joint surface, when the articular surface is elevated, it leaves a void in the tibial metaphysis. This requires a graft to fill the void and also to buttress the joint fragments. Coming to ankle fractures, these are commonly displaced malleolar fractures, which may involve the tibial plafond. 1 millimeter talar shift can lead to 42% reduction in tibiotalar contact, higher point contact stresses, and post-traumatic arthritis. They need to be managed operatively with open reduction and internal fixation. In case of distal tibia medial malleolus, 1 or 2 transfixing screws can be used. In the case of distal fibula lateral malleolus, a screw plate device is used. The precise reconstruction of normal joint anatomy needs to be done to minimize the osteoarthritic changes. Coming to metatarsal fractures, the most common one seen is the avulsion fracture of the base of the fifth metatarsal, which is caused by contraction of the peroneus brevis muscle, a consequence of stepping in a hole, off a step, or twisting the foot. Rarely displaces and heals well with symptomatic treatment. Fracture of the shaft of the fifth metatarsal usually can lead to non-union or delayed union. On rare occasions, internal fixation is indicated. Thank you.